What I wanted to talk about was the topic of transplant renal artery stenosis. I love kidney transplants. I like everything kidney transplant related, and probably the most important topic for a radiologist is transplant renal artery stenosis, because we play a huge role in being able to diagnose, and then from the interventional side, being able to treat transplant renal artery stenosis. So I thought I'd talk a little bit about the journey that we've gone through here at UC Davis to develop evidence-based templated reports, and show you some information about that and how we got to that and where we're going from here. So let's move on. So I started Googling last night what annoys you the most, because I've actually found this to be a very useful tool in having conversations with referring clinicians. When I meet a urologist or a transplant surgeon or a nephrologist or whatever it ends up being, one of the most useful things you can actually ask them is, what annoys you the most about radiology reports or radiology in general? And they really open up. Sometimes a little bit too much, they open up as to what annoys them. But the information that we get from it is quite useful. So, you know, that's one of the things that I try and do when I'm talking with clinicians, is get it out of them of what are the frustrations that they have, or things that they feel like they're not being met as far as radiology imaging is concerned, or radiology reports. So here are a couple quotes, one from a transplant nephrologist, one from an interventional radiologist that was here at UC Davis. And these are real quotes here. The transplant nephrologist just said, "I really don't know what to make of a lot of the ultrasound reports. I just need to know if there is concern for transplant renal artery stenosis." So this is one of the first conversations I had when I arrived at UC Davis. I had a conversation with the head of the transplant nephrology group, and this is what he told me. When I spoke with the interventional radiologist, he said, "We are doing a lot of negative angiograms looking for transplant renal artery stenosis." So you can see that there were problems. So then I started diving into the reports, and I pulled up the ultrasound reports of all kidney transplant related ultrasounds, and I started reading through them. And so here are some of our reports, and these are word for word impressions that we have, which I think lend credence to what the transplant nephrologist was saying. Impression: heterogeneous echogenicity of the left lower quadrant transplant kidney, clinical correlation recommended. So we're not really clinically correlating any kind of differential, we just have heterogeneous echogenicity. I don't even know what that means, let alone a transplant nephrologist or a transplant surgeon. Slight acceleration of peak systolic velocities of the iliorenal artery anastomosis, not suggestive of significant stenosis, clinical correlation recommended. Okay. Slightly elevated velocity of main renal artery at anastomosis, measuring 231.6 centimeters per second, slightly less than 2-to-1 ratio compared to the iliac artery. So you can see where the transplant nephrologist was coming from in our reports. Doesn't give any clear direction as to what we're actually looking at, what we think is going on. We're just reiterating some of the findings that are derived from the sonographers.
Ghaneh, Steve Eberhardt says never use clinical correlation recommended. And also, I hear a beeping sound. Is there a beeping sound in your?
Yeah, there's a fire alarm going on.
Oh, okay.
I closed the door. I tried my best to muffle it,
okay.
But that's what we have. So I can understand the confusion that's being given to our referring clinicians, especially kidney transplant related. So I decided to go in a quest to try and fix this. So the first thing to understand is the role that ultrasound actually plays in transplant renal artery stenosis. We know that transplant renal artery stenosis is the most common vascular complication, but from a clinical standpoint, it's very difficult to clinically correlate transplant renal artery stenosis, because they can present with any number of different clinical scenarios. They could just have hypertension that's refractory to blood pressure medication. They could have severe hypertension. They can have pitting edema. They can have pulmonary edema. They could have elevated creatinine. They can have all three. They can have any combination of those. And sometimes they're actually asymptomatic. So the clinical presentation is not useful. And for them, they have a broad differential. So what they're really trying to understand is, does the ultrasound allow us to be able to take that differential of what can cause those different dysfunctions clinically and actually be able to say, is there transplant renal artery stenosis or not? That's really all they're looking for the ultrasound, especially when you're talking about an ultrasound of a kidney transplant that's more than 30 days out. You're really just looking at those particular, at whether or not this transplant renal artery stenosis going on. Now we know that ultrasound is extremely operator dependent, and depending on who's reading the study, we can have all different kinds of ways of interpreting the same ultrasound. And so we know in the literature that there's a 30 to 40% false positive rate of transplant renal artery stenosis based off of ultrasounds. So, the interventional radiologist saying, I'm doing a bunch of negative angiograms, well, that's supported by the literature, and it was supported when we looked at UC Davis's population, that we had a similar false positive rate. So we could understand the frustration of the interventional radiologist doing a bunch of negative angiograms. Now, the challenge in the ultrasound report standpoint is that there's actually no established criteria for saying whether or not transplant renal artery stenosis exists. We have criteria for native renal artery stenosis, but not for transplant renal artery. So what do we use? Well, we think maybe velocity might be important, but even if we think velocity is important, what is the cutoff? Is it 180 centimeters per second, which is suggested in some papers, or is it 400 centimeters per second as suggested in others? Is the ratio of the velocity of the renal artery and the iliac artery important? Does the resistive index play a role? So there are all kinds of different variables that potentially can go in, and then you can have some that are positive, some that are negative, and ultimately, a lot of times we don't know where to come down on it, so that confusion gets relayed to the transplant nephrologist. So, understanding the anatomy is important. Here we have the most common way that a kidney transplant is done. Here's the external iliac artery. You have an end to side anastomosis with the renal artery to the external iliac artery. Typically, the vein is anastomosed to the external iliac vein, and then you have the ureter coming out. Now, if you have disease within that particular vessel, you can actually have within the external iliac artery, you can actually use the internal iliac artery and do an end-to-end anastomosis, which classically, according to the literature, is associated with an increased chance of stenosis there. And then finally, you can get all kinds of weird kidney transplants. This is something we do quite commonly here at UC Davis. This is a pediatric en bloc kidney transplant, where the pediatric kidneys get so small that eventually you just have to take the whole donor aorta and donor inferior vena cava and take the two really small kidneys that end up being just a few centimeters in size and then transplanting them in there. And interestingly, they can grow quite rapidly into normal size kidney transplants. So when we look at ultrasound, the most important thing that we're doing with ultrasound is actually not visualizing the stenosis itself. A lot of times it's obscured, it's difficult to see the renal artery. So what we're actually doing is inferring based off of the spectral Doppler signal whether or not a stenosis exists. And so understanding what a spectral Doppler is very important. And we know that there are actually three points of information that are placed on a spectral Doppler. One of them is the frequency shift, which is the centimeters per second. The second part is the time, which is along this axis over here. And the third part of it is something that may not be appreciated as well, is the amplitude of signal. And the amplitude of signal is how white is it? So you can see here at this particular point in time, there were quite a lot of signal at 30 centimeters per second at this particular time. Here, in the more gray areas, there's less signal, meaning less reflectivity from what's going on at the same 30 centimeters per second. It's more black. So looking and seeing what this actually looks like is important. All right. Another important background information is that there are three main waveform patterns. One of them is plug waveform, where everything is going the exact same velocity, okay? So when we're looking at the waveform here, because everything is going the exact same velocity, that means at one particular point in time, you can see that whiteness representing the amount of signal is going to be in a very narrow range because everything is going at plug waveform. So that's how it looks like here. You can basically take a pencil and outline it. Everything underneath there, there's not really much signal. So that's what you're going to see in plug waveform. Laminar waveform is what we typically see in rivers when it's just flowing nicely. You go to the edge of the river, there's hardly any velocity. It feels nice and calm. But then as you move centrally into the middle part of the river, you can get swept away because that's where you get the highest velocities. And then when you're looking at a spectral waveform, you can see here the amount of signal is now broadened a bit, but you still get some clarity or some lack of signal underneath the waveform. You get more of a variation of velocities at a particular time. And then turbulence is usually what we see after stenosis. That's where everything is entirely filled in. That's called spectral broadening. You get complete spectral broadening. You get complete filling in because everything is going all kinds of different velocities. And so, we can see this in a river. At a stenosis, at the narrowest portion, you actually get plug waveform. Everything goes the exact same velocity. And so when you look at an area of stenosis, or you look at an area of narrowing within the river, and you look at the bottom, you can actually have the most clear vision of what's going on underneath the river. You can see the rocks really nicely right at the area of the stenosis because of this plug waveform. Here you can see that this is the highest velocity here, but you can actually see at the stenosis, everything is nice and clear. You get plug waveform, and then distal to the stenosis, you're going to get this turbulence going on. So the same exact thing actually happens within a stenosis in the transplant renal artery before as well. So beforehand, before stenosis, proximal to stenosis, we get laminar waveform. That's kind of the typical waveform that we see. The red blood cells bump up against the walls at the edge, so you get slower velocities here and faster velocities in the center. So this is a typical waveform of a normal renal artery. At a stenosis, right at the stenosis, you're going to see plug waveform. And then distal, you're going to see turbulent waveform. So knowing this pattern is incredibly useful in looking at a stenosis. And this exists whether you're looking at a carotid artery stenosis, a renal artery stenosis. Any vascular stenosis is going to have a similar kind of waveform. The other thing you can get as well is distal to a stenosis. You end up getting a parvus tardus waveform, which is defined as a delay in the reach to the peak systolic velocity. Typically, it's 0.1 seconds. To peak is the definition of parvus tardus, and each one of these little hashtags is 0.1 seconds. So in this particular case, this was the transplant renal artery stenosis. You can see the stenosis right here. So you're going to get the normal kind of waveform proximally, then you're going to get the plug waveform, and then distal to that, you're going to get spectral broadening. You're going to get that turbulent waveform. So when we actually looked at all of our cases who had gone to angiography, we took all the cases that had gone to angiography that had an ultrasound beforehand. And since we had a fair number that were actually negative, it allowed us to be able to look at all of the different factors that have been described in the literature, as far as resistive index, the ratio, the highest renal artery. And then we added in spectral broadening because that was something that I was noticing that I was seeing in a lot of patients that actually had true transplant renal artery stenosis. They had spectral broadening distally. And when we put everything in, the only three things that really mattered in being able to figure out the probability of a stenosis was, is the velocity greater than or equal to 300 centimeters per second? Is there spectral broadening? And is there parvus tardus waveforms with an acceleration time of greater than or equal to 0.1 seconds? So those were the only three things that really mattered. And if you had all three things negative, you essentially had a low probability of a stenosis. If you had all three things positive, you had almost a 99% chance of a stenosis, or a very high risk. And then if you had one out of the three criteria, so if you just had a renal artery velocity greater than 300 centimeters per second, but no spectral broadening and no acceleration time, you still had about a 30 to 40% chance of a stenosis. And then if you had any two available that were positive, you had between an 84 and a 92% chance of a stenosis. So we were able to standardize their reports based off of this into these 4 different risk categories. that made it somewhat not dependent upon the radiologist who was actually interpreting it. It gave a standardization to our ultrasound reports when we were screening for transplant renal artery stenosis. So just a couple examples here. Here is one actually where you can see here, this is called the proximal renal artery. The velocity is 108 centimeters per second. Doesn't look like there's a whole lot going on as far as increased velocity. But if you look closely at the waveform, you can see that there's actually spectral broadening. The whole spectrum is completely filled in here. So this meets one of the three criteria. And then if you look at the distal within the transplanted kidney parenchyma itself, you look at the arcuate or the segmental or the interlobar arteries, you can see that there's actually parvus tardus waveform here. So this patient actually, by our criteria, has about a 90% chance of a stenosis, and sure enough, there was a narrowing right at the proximal portion of the transplanted renal artery, and you can see how the sonographer probably put their initial caliper over the proximal renal artery, but missed that actual stenosis here. So, even if you don't have an elevated velocity, you can still have a transplant renal artery stenosis. Okay, let's move on. So we were still having problems with we solved one issue, right? We dealt with the issue of the transplant nephrologist who was frustrated by a report, so we changed that up. But we didn't deal with the fact that we were still having issues with negative angiograms. So this is one of the things that we tried to tackle as well. And what we decided to do is, in patients where there was clinical concern as well as sonographic concern for transplant renal artery stenosis, before sending them to an invasive angiography, we would actually do an MR on them. The transplant nephrologists were concerned about using iodinated contrast, and they were also concerned about using gadolinium-based agents, although that's probably less of an issue. But we ended up using an off-label contrast agent called ferriheme, which the nephrologists were actually quite familiar with because this is FDA approved for iron replacement in patients who have kidney failure. So they're quite comfortable administering this particular agent. It just so happens to be a great MR agent for looking for the vasculature for two main reasons. One, because it has a really long half-life. It's 15 hours that it sticks around as a half-life. And it's also a blood pool agent. So you don't get you get a lot more signal to noise ratio. Your contrast within the vessel looks much better than it does compared with the parenchyma itself, because the parenchyma doesn't really take up the contrast. So you can get these really nice high resolution MRA images. And here's an example of it here. We wrote up a few reports, and there's other people who have written up the use of ferriheme in patients who have kidney transplants or who are being evaluated for kidney transplants. It's gaining some popularity. But you can see with the image quality that you get, you're able to actually say whether or not a stenosis exists. So angiography, conventional angiography, is changed now from a diagnostic tool to a therapeutic tool. So we ended up changing our algorithm. If there was clinical suspicion for some kind of transplant renal artery stenosis, they would go to the ultrasound. And then if the ultrasound was negative, they would get a biopsy. If the ultrasound was positive, it went to angiography. We ended up mixing this up. We added in MR angiography. And then if the MR was positive, they would go to angiography. If the MR was negative, they would proceed to biopsy. So we ended up changing the false positive rate of the diagnostic side before going to angiography quite a bit. So just a couple examples here. You can see the main renal artery really nicely. You can see the segmental artery. You can actually see the arcuate arteries coming around on this ferriheme study. So you can get exquisite detail of the vasculature. So here are just a couple examples. Here we can see the elevated velocity, the plug waveform. Distally, you have that spectral broadening, and then you get the parvus tardus, the delayed peak up there on the images here. Here you can see the UnEnhanced, which is a non-contrast MRA sequence. Here you can see the ferriheme right here, showing the stenosis right here. And here's the conventional angiogram just as a side-by-side. Now, the unenhanced MRA images can have issues. They really rely on things being more straight. Having curved vessels is challenging for unenhanced MRA images. And you can see in this case here, you can't see the artery, whereas on the ferriheme, you can see it quite nicely. And compares quite nicely with the conventional angiogram. It's also useful at looking at for other vascular anomalies. It's not uncommon that people will have dissection flaps, since there's a lot of manipulation that goes on when they're placing the transplanted renal artery. So this is a patient who had a stenosis, but ended up having a dissection flap within the external iliac artery. So the interventional radiologist knew to come from the contralateral sides when trying to fix the stenosis, and then ended up fixing the dissection flap as well. Okay, here's an example here of another use of it, is that they ask us to, the interventional radiologist asks us to give table positioning based off of the 3D reconstruction, which we're able to do. That way, when they shoot dye into the external iliac artery, they know that they're going to be able to see it on the first time that they inject contrast, and they're able to see the stenosis optimally. So here's actually the ultrasound structured reporting that we have now. I like to keep things pretty simply. I've actually taken out almost all numbers from all of our ultrasound reports, and I didn't want to make transplanted kidneys an exception to our trying to take out all velocity. So you can see with echogenicity, we just say normal or increased. The urothelium, I'm not going to talk about in this one, but we found it to be quite useful in looking for rejection. So we just have normal and thickened. Hydronephrosis, peritransplant collections, perfusion, intraparenchymal resistive indices, and veins. This is just our standard look here. But then for the transplant renal artery stenosis, which is really what the transplant nephrologist usually cares about, we have the 3 criteria here. Are they met? Yes or no? And so then the impression is transplant renal artery stenosis screening risk category. We're able to risk categorize it, and then we're giving them information that they can use to be able to decide whether or not to go to the next step, which would be an MR with ferromoxetol.
Ghaneh, so for the resistive indices, if you go back a slide,
yeah.
you give low, normal, high, but they're not defined there. Can you? Yeah,
so there are various definitions that are used. We use low as less than 0.6, normal is 0.6 to 0.8, high is 0.8 to 1, and reverse is over 1. And so, within our templated reports, if you hover over them, it'll actually give you those particular parameters within them.
Cool. And then Amr is asking to elaborate on the previous slide, the one with contrast MRI.
This one?
Yeah, I think he's talking about that one. I guess, are you asking how he got the table positioning? Yes, he's asking how you got the table position. So when you did your 3D reconstruction, it gives you these LAO and stuff, or?
That's correct. So we use TerraRecon, but other vendors have similar things where when you actually do a multiplanar reformatted image, it will actually give you what are the table positioning that would allow that particular vessel to be viewed. So we actually provide in our reports of the MRI, what are the table positioning if there's a positive stenosis, so that the interventional radiologist can go right to that particular table positioning and get the same kind of imaging. So our interventional radiologists really like having this information, and even in cases where they know that there's a stenosis and they want to fix it, they still want to get the MRI so that they can have that particular information.
Yeah, it's very cool.
Okay, so that's our ultrasound structured reporting. It's kind of based off of somewhat flawed data, because the way that we were able to figure out whether or not what the ultrasound things were important it was a pre-screened population. It was individuals who had undergone angiography. So these were patients who were probably pretty high risk to begin with. So one of the things I was curious about is, since we've implemented the reports, how have we done? And this is one of the things I was working fast and furiously over the weekend on, and actually finished it last night around midnight. So if there's any data that's incorrect in here, I apologize. But when I looked at the number of ultrasounds we've done since 2017 of July, when we started implementing them, we had about 900, I think 930 ultrasounds that were done, of which 539 were really to evaluate for transplant renal artery stenosis. We, as an institution, do immediate post-operative ultrasounds. I didn't include that in these ones because they're not really looking for transplant renal artery stenosis. Transplant renal artery stenosis doesn't really exist in the immediate post-operative period. So I excluded those ones. And I just looked at patients as well who the clinical indication suggested some kind of stenosis evaluation. So there were 539 ultrasounds. And then when you look at the different groups, the vast majority of them were in the low risk category. That was 71%. And the very high category was 5% of the ultrasounds. When you look at the MRIs that we've done 73 ferromoxidil MRIs within this patient population, overall 14%. But you can see that the clinicians are actually sending patients for MRI based off of the risk, that the higher risk they have, the higher chance that they're getting the MRI. And also, I think this is more interesting, even of those that are screened and get the MRI based off clinical and ultrasound information, those who have very high risk categories end up having the higher risk of having a positive MRI study and going on to angiography. So you can see that the risk stratification scale seems to work. Again, this is unpublished data, so I apologize if there's anything incorrect with this or things that we might iteratively change later on. Okay, let's look at another thing. Impression, very high velocity in the main renal artery near the anastomosis, 416 centimeters per second. Possibility of stenosis at the anastomosis should be considered. This is another report that we had before we implemented our standardized report. This is a quote from a transplant surgeon. "Every time you call the stenosis anastomotic, I feel somewhat responsible, even though I know I didn't do anything wrong." So this is one of the things that I was kind of interested in, is that the transplant surgeons take it somewhat personally every time you call something anastomotic. And this is kind of based off of some of the radiology literature that's out there that calls most of the stenoses occurring at the anastomosis. So we decided to take a look at it. I worked with a transplant surgeon to take a look at it. And this is how you have a normal, most cadaveric kidneys come with this patch of donor tissue called Carrel patch that's implanted on the external iliac artery. And so, the anastomosis is where? We tend to think the anastomosis is here, but in reality, it's usually this big patch that's actually the anastomosis. So most patients who get kidneys, they come from deceased donors, and most donors have Carrel patches. So calling them anastomotic is probably an unfair thing to do. So we ended up looking and trying to figure out, well, where does transplant renal artery stenosis occur? And we know it occurs pre-anastomotic. You can see it within the iliac artery, sometimes the common iliac artery or the external iliac artery, proximal to the transplanted kidney, to the transplanted renal artery. You can also get it at the either anastomosis, if it's truly anastomosed here, or what I've termed the ostium in patients who have a Carrel patch. And then you can also get it in the main renal artery, and you can even see it distally in the segmental renal artery. So here are just a few examples here. Here's a proximal renal artery stenosis. So this is actually a patient who had a Carrel patch. So this would probably be referred to as an ostial stenosis. Here's another example here. You can see this narrowing in the mid-renal artery here. So this is a mid-renal artery stenosis. And then here's a case where it's just so diffuse that it's kind of a multifocal stenosis. So you can see there's quite a lot of variety when we're talking about what stenosis actually is and where it's located. When we actually looked at the data of over 100 patients who had transplant renal artery stenosis, you can see 45% of them actually involved the main renal artery. And of those that were kind of that osteoanastomotic, which was 35% of them, most of those ended up being ostial. So those that are actually anastomotic, that you could actually say, well, maybe there was something associated with the anastomosis itself, it was only 12% of patients. We also found some kinks, 5%, pre-anastomotic, 4%, segmental. We had a case of FMD in a transplanted kidney. I thought that was kind of interesting. And then you also get internal iliac artery stenosis, which, I told you before, we think that internal iliac artery stenosis is actually quite common. It's actually quite rare in our group. We had 1 out of 49 patients who had internal iliac artery anastomoses, which was 2%, ended up getting a stenosis there. Whereas conventional, going to the external iliac in an end to side fashion, there was about a 5%. So internal iliac artery actually may be safer in some circumstances than conventional anatomy. For living donors, their rate was really low. There were actually only 2 real cases of stenosis in living donors, so 2 out of the 739. 3 of them were pre-anastomotics that has nothing to do with the actual transplanted renal artery. So it's actually 2 out of the 739, or 0.3%, so very, very low. Most of them came from the deceased donor population. There was 95 out of the 1957. So just wrapping it up, does anyone remember this movie, Kindergarten Cop? It's not a tumor. Well, Arnold Schwarzenegger, if he were a transplant surgeon, would tell you it's not anastomotic. So, try and take that out of the reports. Otherwise, you may get a transplant surgeon who kind of looks like this when they're reading the report. Last point I want to bring up is what causes transplant renal artery stenosis? We have no idea. This is, again, data that I did on my laptop and put together quite a large number of patients who both had stenosis and didn't have stenosis that we compared. And we looked at a bunch of different factors. KDPI is the overall functioning of the kidney before donation. It takes into account 10 different factors to give a score as to how good is that kidney when they're putting it in. The pump is whether they put it in a pump before they put it in the patient. The cold ischemic time is how long it's been out of the patient. Reconstruction is whether the transplant surgeon had to manipulate the vessels and reconstruct it. And then donor age is self-explanatory. Those are the only things that ended up being significantly associated with transplant renal artery stenosis. And we're going to go actually into the kind of subgroups and see if there were particular patterns that the subgroups have, but I don't have that data back yet. And this is a univariate analysis. We're waiting for multivariate analysis to come back. Finally, a lot of people talk about clamp injuries, and that's in the literature as far as being a cause for transplant renal artery stenosis. Clamp injuries do not cause transplant renal artery stenosis. You can see here, here's the external iliac artery, and you get the renal artery being anastomosed to the external iliac artery. The only place they place the clamps are in the external iliac artery. So if you have a pre-anastomotic stenosis, it's a possibility it may be related to a clamp injury or to underlying atherosclerotic disease, but there's no clamps that actually go on the renal artery itself. So, transplant renal artery stenosis is not a clamp-related injury. Okay, so the other thing to remember is it's not a clamp injury. So it's not anastomotic, it's not a clamp injury. So just in summary, transplant renal artery stenosis can be evaluated in ultrasound based on 3 criteria: the velocity, the spectral broadening, harvest TARDIS waveform. We use that as a templated report to make sure that we're all saying the same thing and we're able to convey that information. Prior imaging, either with MRI, you can use gadolinium, or with CT, you can potentially use iodinated contrast. It might be advisable before undergoing conventional angiography, just because our false positive rate of ultrasound is still quite high, even using a template. TRAS is usually not anastomotic, and we don't really know what causes TRAS, but it's likely multifactorial. That's it.
Awesome. I can't believe your data is hot off the presses. That's cool. Anybody have any questions?
Hey, Ghaneh, what about contrast-enhanced ultrasound? Since you have the patient in your lab already, why not use that to troubleshoot these potential stenoses?
Yeah, very good question. It's a possibility. We have noticed in some patients that we're able to see it. We also use B-flow. We found that to be quite helpful in trying to actually look for a stenosis. It doesn't pan out as well as MR angiography, just in my opinion. I think it's a useful tool to try out. If you can see it and you can have confidence in it, that's great. I know our interventional radiologists would still want to get the MR just so that they can have that roadmap and know what they're dealing with ahead of time. Because things like that dissection flap, which is actually not uncommon, or being able to see a stenosis, a really long segment stenosis is useful, because sometimes not every stenosis that's visible is actually treatable. That one that I was showing of that diffuse stenosis, even though that might show up and would be visible on angiography, is not treatable. There's nothing they can really do to treat those particular types of lesions. So I do think ultrasound contrast has a role, and it can be used from institution to institution, but I think MR would probably be, in my opinion, with ferriheme would be a better gold standard.
Steve Eberhardt says, great lecture, better than most references I've read on the topic. Do you have all this in a review paper that you have published?
No.
Not yet.
No, not yet. You know, we had I was invited by Abdominal Radiology to do a special section on kidney transplant. So I think it was a couple years ago, we did 2 or 3 years ago, we did a special section on kidney transplants and invited a bunch of people. And I think I wrote one on vascular complications. But, you know, a lot of the data has changed just based off of the past few years and what we've been doing and how we've been changing our practice here, that, you know, probably something else needs to be written at this point. But I kind of wanted to get this data out first and figure out what it means and work on the discussion of that before having, you know, a review paper on it.
Cool, awesome.